Assalamualaikum doctors. In this video I am discussing how can we manage glomerulonephritis, acute glomerulonephritis. So chief complaints can be headache, hematuria. First of all, the differential diagnosis we can put for acute glomerulonephritis. It can be a sequelae of other bacterial or viral infections. It can be chronic renal failure with acute exacerbations. Immunoglobulin A nephritis, Henosqualin purpura, immunoglobulin A nephropathy, mesenteric capillary glomerulonephritis, Alport hereditary nephritis, ANCA positive vasculitis, anti-GBM disease, and SLE systemic lupus erythematosus. So, what are the systemic symptoms and signs of glomerulonephritis? I am telling. They have a macroscopic hematuria, Coca-Cola colored urine. Remember, macroscopic hematuria, Coca-Cola colored urine. History of sore throat in preceding 2 to 3 weeks before. Reduce the urine output, oliguria, urine output, infant and child less than 1 ml per kg per hour. They have hypertension. So, plus minus features of encephalopathy, headache, nausea, vomiting, visual disturbance, restlessness, and confusion. Headache or breathlessness could be indicative of pulmonary edema. Sign of cardiac failure, tachypnea, raised jugular pressure, gallop rhythm, basal fracas, and enlarged liver. So these are, understand that. And what examination we do? So features I'm telling, there is macroscopic hematuria, Coca-Cola colored urine. The most important 2 to 3 weeks back there is a sore throat history we find. A history of encephalopathy, headache, confusions, hypertensions, and these are, and also breathlessness can be present. Mainly urine output is reduced, oliguria and urea. Examination, we do the ABC vitals, especially the blood pressure, weight, and jugular pressures. If raised in this indicates the volume overload. General examination for edema, chest examination for possible pulmonary edema, cardiac examination for possible heart failure or murmur, and abdominal examination. So examination and ABC vitals, especially the blood pressure, weight, jugular pressures, general examinations for the edema, chest examination, cardiac examination, and abdomen examinations. Chest are for pulmonary edema, cardiac for heart failure or murmur, and abdomen examination. Investigation we run, first of all, urine dipstick, more than 3 blood with proteinuria, protein creatinine ratio, microscopy, red cell granular fast. Blood urea electrolyte low sodium is likely to be dilutional. Albumin usually normal or low normal. Calcium phosphate, liver function test, CBG, CBC, blood film hemolytic uremic syndrome, and coagulation profile. So microbiology, anti-streptococcus ASO titer we are doing, anti-DNase B, throat swab for group A streptococcus. Immunology complement C3, C4, anti-DNase B, skin, and the double-stranded DNA, ANCA, anti-GBM. Discuss with the nephrologist, imaging, renal ultrasound. So these are the investigation we do: urine dipstick, early morning urine proteinuria, urine culture, urine routine microscopic examinations, ASO titer, then throat swab cultures, throat swab for group A streptococcus, complement C3 level, C3 C4 level, renal ultrasound, full blood count, electrolyte level because sodium is low, normal. These are we do. And complement abnormalities I am explaining. First of all, normal C3, normal C4 found in immunoglobulin and nephropathy, Henosqualin purpura, ANCA positive glomerulonephritis. But low C3, normal C4 we find acute post-streptococcal glomerulonephritis, mesenteric proliferative glomerulonephritis. Low C3 and low C4 we find SLE, mesenteric proliferative glomerulonephritis, shunt nephritis, and IEC. Treatment is multidisciplinary team, pediatrician, nephrologist, and dietitians. Review the recurrent medications and reduce the dose. Stop all nephrotoxic medicines. Administer strict fluid balance. Diets low salt, low potassium, high carbohydrate. Low salt, low potassium, low salt, low potassium, and high carbohydrate. Treatment of hypertension and edema, furosemide. Antibiotics are phenoxymethyl penicillin if tolerate, able to take tablet, or amoxicillin suspensions for 10 days if penicillin allergy, azithromycin for 5 days. Post-streptococcal glomerulonephritis, PSGN. So treatment, first of all, we maintain blood pressures. We give the phenoxymethyl penicillin. If not, oral suspension amoxicillin. If azithromycin, if penicillin allergy. Mainly the strict fluid balance diet, low salt diet, low potassium diet, and high carbohydrate. Nephrologists, pediatricians, and dietitian will involve. So when we discharge this patient from hospital, patient may be discharged when all following criteria meet. First of all, blood pressure under control, passing urine normally on free fluid, renal function improving, and normal serum potassium. Blood pressure under control, passing urine normally on free fluid, renal function improving, and normal serum potassium. Follow-up for prognosis of glomerulonephritis is that macroscopic hematuria, oliguria, chemistry resolves 2 to 3 weeks, blood pressure improves by 1 month, serum C3 improved by 2 months, proteinuria resolves by 6 months, and microscopic hematuria by 1 year. What is the indication of tertiary referral when we refer the tertiary? First of all, significant proteinuria, UPCR more than 200 mg per millimole. Family history of glomerular disease, microscopic hematuria more than 2 years, macroscopic hematuria more than 2 weeks, persistent proteinuria, oliguria, acute kidney injury, hypertension, low C3 for 8 weeks, positive ANA, anti-double stranded DNA, anti-GBM or ANCA, recurrent nephritis. So, proteinuria, hematuria, hypertension, recurrent nephritis, there is any family history of disease, microscopic hematuria, complement level low more than 8 weeks, recurrent nephritis. These are will refer to tertiary hospital. Thank you.